Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by Village MD, primary care physicians, practice medicine the way you've always wanted, data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Hi, welcome to Working Smarter. I'm Wendy Rubis, General Counsel of Village MD, and I'm here with Janessa Nelson today.
Hi, I'm the Legal Operations Analyst at Village MD.
So, Janessa, we got a lot of great feedback about our physician payment reform podcast, and one of the things we heard is that people wanted us to focus a little bit more on the new codes for new services.
And they're really complicated. So the hope of this video is to deep dive a little bit further to give you more information. And this is exclusive content for anybody working with Village MD.
That's great. Exclusive content sounds so sparkly. I love that. Okay. So we've got 3 codes to cover today. We're going to give you a little description of these, but part of the exclusive content, we also have downloads for you that we can make available to you so that you can share these with your staff or post them in your office so that you can have exactly all the details. Like any codes from Medicare, there's a lot of detail to these, but we're going to just kind of cover the highlights. So the first one, and again, we think these are great news for managing complex care. The first one is basically a virtual check-in, or as Medicare likes to call it, a brief communication technology-based service. That's actually what they call it.
That's so CMS. It has brief in the name, but it's not a brief description about what it is.
Another way of thinking about the brief communication technology-based service is it's a phone call. You could just say a phone call.
Yeah. Or to be fair, this is more expansive. So anything where you can have an audio component attached to it.
Yeah, that's an important point. The technology, there's lots of buzz about the technology, and you hear people use the word telemedicine, which in Medicare, telemedicine has a very specific meaning, and it means it can only be used in shortage areas, and it has to be certain equipment and all of that. So technically speaking, this is not telemedicine, even though it's a telephone. And any technology, as long as it's audio, and as long as it's interactive. It can be a lot more fancy, but at least it has to be that.
Okay. And it looks like this is only for established patients. Is that right?
That's absolutely right. And anyway, even if it wasn't, we would not recommend having a phone call and diagnosing or treating a patient
that you've never met
it just
before.
Could be risky, but so that's not a terrible, it's kind of a common sense thing. So yes, it's only established patients.
And because this is a billing code that you're going to be submitting, this has to be from a provider. So you can't bill this if it's just a medical assistant is seeing them. They talk to a receptionist.
That's absolutely right.
Yeah.
It's a provider, meaning physician, APN, PA, someone who can actually bill, not incident to someone office staff.
Exactly. And then how often are they able to do this?
That's a hot topic and hotly debated. And interestingly, there was no frequency limitation put on it.
Whoa.
Yeah. So, however, keep in mind that this is acceptable to bill if you haven't seen the patient in the last 24 hours and they don't come in the next 7 days. So that's a spatial time kind of. So the point is this avoids a visit.
Oh, okay.
So this avoids a visit. And they just talk, which I would love, because you just talk to them on the phone. Hey, do I need to come in? Should I be worried about this? No, don't worry about it. Thank you. Okay, then I don't come in.
And a lot of PCPs are doing things like this, but now they're able to bill and actually get money for all the small little things that they're doing in practice.
I think it could be great. Now, that you're hitting on a sensitive area, because I was talking to some folks here and I was excited about this, and immediately they said our physicians are going to struggle with this because they talk to patients. That's just considered a part of what they do, and they're not, because of course this is a Medicare Part B, so there is a copayment. Patients would experience a copayment with this bill, and so that's something that you would have to tell the patient, and they would have to consent. That raises questions: what if they don't consent? So there is a little bit of wood to chop there in terms of how to work that out.
You need to think about who your population of patients are, the specific patient. But I think having that discussion with the patient and getting their okay, it could save them a whole trip, which can be a long trip for some patients.
And I think especially patients who are chronically ill, it may be difficult for them to get out of that. I think a lot of patients would understand and appreciate this.
But once again, you need to talk with your patients and you need to figure out what's right for your practice.
That's exactly right.
So there's this other one, remote evaluation, which, is this the same thing? I'm confused.
Good question. This is remote evaluation, which again, you're probably thinking, so is the phone call.
Exactly.
But what this is, they call it store and forward. Have you ever heard of that?
No.
No. Store and forward, actually, I have to admit, I wasn't familiar with it either, but there's already store and forward codes in the CPT and that Medicare approves, but they're for other specialties. Like if you're doing heart monitoring and it's collecting data, you can forward that over.
That makes sense.
The read of that is something that can be billed. So this is just expanding the store and forward broader to primary care and other physicians. So this is what they call asynchronous telemedicine.
No.
Which is basically a way of saying the patient has to initiate it and they are sending you can see our example if you're watching the podcast video, but we like to joke, okay, this is a rash. Is this a rash? And it's really a tattoo, which
funny because it's probably happened.
I don't want to talk about it.
Leave us a comment if this has actually happened.
Right,
too.
if it has happened, it'd be funny. But so they send you an image, and we actually would love to hear from our physicians if this is something that you can relate to. I can't think of a time I've ever sent an image of some kind to a doctor, maybe a pediatrician. I don't know. So if this is something that our physicians are encountering, I don't know. But the idea is there's pre-recorded audio and or image, even video, and it's sent over, and the physician has to interpret it and follow up with the patient within 24 hours. This does not originate from a visit. And so you haven't seen the patient. It's not like the patient came in, you go, hey, when you get home, send me a picture when that happens. And no, that's bundled into the visit, okay? Mm-hmm. This is in lieu of a visit, same like the other one.
And once again, because this is in lieu of a visit, this has to be with an established patient. You can't just quickly diagnose off of someone you've never met before.
Which hopefully, again,
common sense.
If someone that you don't know sends you a picture of a rash, I don't know. To me, that would just be delete. Please, and just by the way, in case anyone was wondering, please do not send the general counsel of Village MD
pictures of your rash.
Any pictures of rashes, because I don't want those. Okay. So for store and forward, there is also a co-payment and the consent issue still there. No frequency limits, just like the other. But I mean, how many rashes do they have to send? I don't know. But the time frame of the 24 hours and the 7 days is still there. I think maybe we said that. Okay. The last one is, again, these names.
And we talked about this in our last video a little bit.
We did. But these names, so we don't have a CMS branding namer. They don't have a namer. So this is Interprofessional Internet Consultation.
So essentially you're talking with other physicians.
That's right. This is also known as a phone call with another physician.
Sounds good.
Right.
That makes more sense to me.
Now, you might be thinking there's already codes for this. And you'd be right. There are codes for interprofessional consultation before this change. Going back to 2014, there were CPT codes for assessment and management by a specialist or a consultant, but only the consultant could report those codes. And that required a verbal interaction and also a written follow-up report. This, as of 1/1/19, is a new code, two new codes, 99451 and 99452, which again, you can get all this information from our handy guide that you can download. But this is to be reported not only by the consultant, but also by the requesting physician, the treating, what did we call that? Is that the spoke or the hub?
The hub.
That's the hub.
Yeah.
This is, if you're the hub, this is you, okay?
Yeah.
And our primary care physicians, major hub.
Oh, definitely. I mean, and there's, especially with chronically ill patients, there's a lot of care and coordination between specialists that primary care physicians already do. And so this is an ability to bill and to get money for doing all of that extra work. But once again, let's remind you that the patient will get a bill for this. So you need to understand who your patients are, if that's okay with them, and if that's okay with you.
There's some EQ and there's some working out of how to get their consent that we will have to help you with. But I want to encourage everybody, because I know there's a lot of trepidation about charging patients, but I can just tell you, my father-in-law, who has many, many comorbidities, complex conditions, if the physicians would talk to each other, we would absolutely be more than happy to pay a co-payment for that. That is so critically important to managing the care. And it's such a relief to the minds of patients to know that their physicians are communicating and that they're not the ones carrying the water in between and explaining and so on.
And it also might decrease the amount of times they have to come into the office, which actually may end up saving them money. So this is sort of you need to figure out how this works in your practice and in what situations it'll work for you.
Right. And so now one nuance here is this is new and established patients. But if you think about the reason for that is that the specialist or the consult may not have a relationship with this patient. So it could be new for them. I think we would probably expect our primary care doctors to mostly be doing this in the case of established patients. Although it could be a new patient got attributed to you the first time you're seeing, who knows? There could be situations, but importantly, this is new and established. And there is a frequency limitation on this one. Once every 14 days.
Which can actually still be quite a lot.
It's not terrible.
Yeah,
it's not terrible. But you can't just spend all your days, which you probably could on some of these patients, spend a lot of days just making calls. All their I know family members that have many specialists. But once every 14 days, and it's assuming that you're talking for 16 minutes, which is
that's a long time actually.
Kind of a funny amount of time.
Yeah.
16, not 20, not 10. 16 minutes.
Did they take an average?
I don't know.
Have they been listening on our calls?
I will tell you, I know there's a good reason for the 16 minutes because these guys are super smart, but I don't actually know what it is. Now, another question people have asked me is, can it be billed by both? Yes. The point is, we're talking, Janessa, you're the hub, I'm the, what's the other one?
Specialist.
So we're both billing. Yes, we can both bill. Same issues with the patient consent we mentioned. Bottom line, and this is a reminder from our previous conversation we had, that these new codes are effective already, 1/1/19. If you're working with Village MD and you need help with these, let us know. We've got lots of things we can do to help you. And don't forget, it's a good time to work with Village MD. It's cheesy. We said it was cheesy last time.
It's still cheesy, but
sincere.
The sentiment stands and is sincere.
True. It's sincere.
And we appreciate all of you that are working with Village MD. We're so happy that you're working with us, and we hope to keep providing you with great content.
Right. So thanks for listening. We hope to talk with you again about this and other important topics.
Thank you to our sponsor, Village MD. We hope you will join us for future concise compliance conversations.